So this paper that I had put together with Mike Pulsifer and Nirali Shah was really sort of taking a look at the 10 years that we've had of treating patients with CAR-19 therapy and putting together what we've learned. Who are patients who are really likely to do well with CAR-T on their own and achieve a long-term durable remission, and who are patients that are more likely to experience a relapse or have failure of a CAR-19 product. And so we put that all together into a How I Treat article to really try to risk stratify patients who are getting CAR-19 therapy to be able to then guide management of patients following CAR-19 therapy. So for instance, our lowest risk patients are patients who are coming into CAR-T earlier in their disease course without tons of relapses and are coming in with a low disease burden. And then at day 28 after getting CAR-19 infusion, in addition to being in a complete remission, they have no evidence of even really low level of disease by next generation sequencing. We know those are patients with extremely high event-free survival with CAR-T alone. And so those are the patients that we say continue close monitoring, but unlikely to need other therapies. On the flip side, you can take some of your highest risk patients. So for instance, patients who have had many relapses before, who come into CAR-T with high disease burden, they get CAR-T infusion, and at day 28, they may be in an MRD negative remission from flow MRD, but have a little bit of something detectable by next generation sequencing. Those are the patients we say, that's really our highest risk patients. Those are patients that you need to monitor extremely closely and think really early to give them additional therapy, and whether that's take them to a transplant, take them to an experimental CAR-T product. And so we propose there's not a huge amount of data to guide every single recommendation that we put in there, but we took all the data that we've gotten from various multi-center consortium, single center studies, both in the US and really some awesome studies coming out of the European groups, and tried to get as much data together as we could to sort of inform these different risk groups that we had. And then in the paper, we put together a proposal of different risk groups and what we would do to treat those patients and what we would recommend for monitoring strategies.